Okay, so this is the first video on respiratory physiology. We're going to look in this first video at the general kind of what is the respiratory system, what are the organs involved, the differences between pulmonary and cellular respiration. We'll discuss what's called the conducting versus the respiratory zones, talk about the rhythmic system and the relationship of the respiratory system with the rest of the body, and then focus on what's called the respiratory epithelium, which is the main epithelium that lines most of the respiratory tract. And then in coming videos, we'll look at the upper respiratory organs, lower, and then kind of talk a bit about the generals of respiratory physiology. So respiration can really have two meanings. What most people think of as respiration is the pulmonary respiration, and that's the exchange of oxygen and carbon dioxide between the human being, in this case, and the environment. And that occurs in the lungs, specifically in the air sacs, and those are called the alveoli. Now, importantly, most of the tubes in the lungs, where the air is conducted from the outside into the alveoli, are part of what's called the conducting zone. They don't actually exchange gases. So gas exchange happens at the alveoli only. There's another type of respiration, though, and that is cellular respiration, and that happens in the cells at the level of the mitochondria. And so this is anaerobic metabolism, and the end product of that is the generation of ATP. So we can really differentiate the two. They are related, of course. So it's interesting to think about how mitochondria can be likened to the inner lungs of the cells. That's actually the organelles that are breathing and doing that process. What's interesting is that sitting up on the openings of the lungs, up on the trachea, right below your larynx, is your thyroid gland. And the thyroid gland secretes thyroid hormones. And interestingly, in the tissues, one of the effects of thyroid hormone is to increase the number and activity of mitochondria. So it's interesting how the lung system in general, we can think of as including all that. The lungs, the thyroid, the mitochondria, all is one interacting process. Now we can divide the respiratory system into an upper versus a lower respiratory tract. So the upper system really would be your nasal passages, your paranasal sinuses, and there's four of them: the frontal, maxillary, ethmoid, and sphenoid. There's actually the frontal and maxillary ethmoid are bilateral, so there's actually 7 total sinuses. The pharynx, which is divided into the upper pharynx, called the nasal pharynx, the oral pharynx, and the laryngeal pharynx, and then the larynx above the vocal cords. By definition, this is the upper respiratory tract. The lower respiratory tract would be below the vocal cords and the larynx, the trachea, the lungs, and that would include the primary airways, the bronchi, and those are divided into primary, secondary, tertiary. We'll look at those. Bronchioles, terminal bronchioles, respiratory bronchioles, which lead into alveolar ducts, the alveolar sacs, and then the alveoli are part of the alveolar sacs. Now this is important because in clinical practice, when we look at, for example, respiratory infections, a lot of viruses will infect the upper respiratory tract, but they don't have an affinity for the mucosa in the lower respiratory tract, and vice versa. So we can kind of start dividing upper versus lower respiratory disorders in some of the clinical phenomena that we'll see, and we'll get into that more in the pathology section. Finally, another important division is to look at the difference between what's called the conducting zone, and that would be basically from the nose all the way down to the terminal bronchioles. So that includes the pharynx, larynx, trachea, bronchi, bronchioles. There's no gas exchange that happens with the tissues. This is purely tubes to warm, filter, and moisten the incoming air. There is local immune defenses, like with macrophages, and we'll look at that in detail. And then the mucosa is lined with what is called respiratory epithelium. And that's a very special type of epithelium. It's ciliated, and again, we'll look at that in detail. The respiratory zone would include the respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. And this is really where gas exchange occurs. And the mucosa is very simple. It's simple cuboidal, and in the respiratory bronchioles, and then it becomes squamous epithelium, the really flat, thin epithelium down in the alveoli. So alveoli are just really a thin wall of squamous epithelium, and this is really where the gas exchange, oxygen is getting into the body, CO2 is going out. Now, in terms of medical specialties that deal with the lungs, a pulmonologist is a specialist in the diagnosis and treatment of lung diseases, just so that you know. And an otorhinolaryngologist, ENT doctor, we can think of that is the ears, nose, and throat doctor, is someone who specializes in the treatment of ear, nose, and throat disorders. So both of those specialists will be potential referrals when we start looking at the respiratory pathology, people who would deal with these respiratory illnesses. Now, going back to a much earlier discussion we had about the basic processes in the body, there's really three fundamental physiologic processes. One would be your information exchange processes. So that happens largely in your nervous system, where signals are sent out, and that helps to actually inform and really form tissues. So if we ask what keeps the form of your body, it's really your nerve activity, which is working into tissues. That's why you have the certain shapes in the organs and tissues that you have. And this requires that we have sensory neurons, we have receptors and all that kind of thing to go back and forth. So this form activity, again, could be thought of as centered in the nervous activity. On the other hand, we have our metabolic activity centered in your digestive organs below your diaphragm. Now, important to realize we have nerve activity in the intestines and the digestive activity. Vice versa, we have metabolic activity in the nervous system. So it's not really spatial isolation, but these are two polar opposite forces. Your form-giving activity really is about information exchange, you could say immaterial activity, using very, very small amounts of neurotransmitter hormones that are diluted to homeopathic levels, etc. Versus in metabolism, we're dealing a lot with substantial metamorphoses of matter. So we're taking foodstuffs, breaking them down, rebuilding them back up into glycogen and protein and so forth. So that's the metabolic. We can say on one end, your nerve sensory activity, information exchange connects you with the sensory world. We might even say the spiritual world of thought and so forth. And then the metabolic system connects you more with the material forces of the earthly world. Well, in between, we have rhythmical processes. So we have the circulation of the blood, which carries nutrients from digestion up to the nerve sensory system, carries hormones and whatnot down from the information centers into the metabolism to regulate it. And then we have the breathing rhythm, which is important for setting the rhythm in, for example, your cerebral spinal fluid and so forth. So we can think of the lungs really as having both the heart and the lungs, as having an affiliation more with this middle rhythmic system. And in the old language of alchemy, these were looked at as separate processes. So they called the information forces, the form-giving forces, the salting process. As an activity, they're very yang, but as substance, they're very yin. So nerves really are kind of dead. They don't have a lot of life activity, but they conduct and carry information. Versus your metabolic tissues, this was referred to as the sulfur activity, hot combustion, and this is very sort of yin in activity, but yang in substance. So if you look at, for example, glycogen or fat, it stores a lot of energy. That's the heat and warmth that's trapped in matter. So the matter becomes very yang, but it's more storage. It more provides sort of the substrate for the rest of the body. Versus in the heart and lungs, we have a rhythm, and this was called mercury in the old alchemical language. Mercury, like a blob of mercury, can exist either as a rounded formed bead or as a more diffuse puddle. And so it kind of alternates between these two forms, and that's kind of what we can think of the breathing process doing. We can think of every time we breathe in, we actually bring these information exchange processes into the body. Every exhalation, the metabolic processes more make their way into the body, and so forth. So the lungs hold a sort of balance, and there's a lot more we can say about, for example, the ratio of the pulse rate to the breathing rhythm. Those are important physiologic parameters. But the important thing here is just trying to relate the lungs to the rest of the body. We can think of it as more relating to this middle rhythmic zone. Now, of the two, the heart and the lungs, we can think of the lungs as actually having more of an affinity for the information exchange processes, for the nervous system. There's something very nerve-like about the lungs. In fact, one of the problems of having too much of this formative activity is a state of chronic hardening or sclerosis. Just like having too much metabolic activity, we get too much acute inflammation. And what we'll see with especially chronic lung diseases, they tend very easily to hardening fibrosis, sclerosis. So a lot of these chronic lung diseases are associated with a lot of fibrotic deposition in the lungs. There are, of course, acute lung diseases with the acute inflammation like pneumonia, bronchitis, and so forth. But those usually are short-lived, and it's more the chronic inflammatory and sclerotic processes that often take hold. Important to remember in the idea of salutogenesis. Salutogenesis, again, is an approach to medicine that really attempts to support the healing forces in the body, those forces that maintain homeostasis, versus addressing pathogenesis, which is like suppressing inflammation, tumors, things like that. In the salutogenic approach, inflammation, acute inflammation, is actually seen as a healing mechanism for too much sclerosis. And so interestingly, we can think of a lot of acute lung conditions like pneumonia and bronchitis as actually the body's attempt to heal you from too much hardening sclerotic activity that descends into the lungs. So we'll come back to that in pathology, but it kind of gives you this notion of how the lungs stand in the balance with the whole rest of the human being. So the important thing about the rhythmic system is that it encourages the body rhythms. So of course the heart and the cardiac muscle cells, the electrical signal of the heart, the EKG, that is sensed by every cell in the body, and it sets sort of the rhythm in the body. Well, same with the breathing rhythm. We can say that sets the tempo for metabolism and a lot of other factors. So here is a mediating element there. We can say with every inspiration, what happens to breathe actually is, breathing is really, in terms of inspiration, it's an active process where basically the diaphragm, which at rest is usually kind of curled up here, with breathing, the inspiration, the diaphragm contracts, and that actually makes the chest cavity bigger, and that's going to actually pull air into the lungs. So inspiration is an active process. We can say it requires the nerve sensory system. Remember from neurology, it's the phrenic nerve, which has origins in the C3, 4, 5 area, is what innervates the diaphragm. So you need to stimulate the phrenic nerve to initiate inspiration. So that's an active process. We could think of the lungs becoming more head-like. And if we start talking more in a soul spiritual sense, we can say that on inspiration you inhale your hun subtle body, or what in the Western tradition was known as the astral body, that comes and connects with the physical body more strongly. Versus exhalation, the diaphragm relaxes and the hun is able to leave, but now the living forces, the po and all those etheric forces which repair and restore your life activities, become predominant. So with every inhalation, we become more head-like. Our consciousness increases. We become a little bit more alert. With every exhalation, we sort of go to sleep a little bit. We become more plant-like. So there's this alternation there. And we'll see with the cardiac system, the same thing happens. With every heart contraction, systole, we become more head-like, more animal-like, more alert, conscious. And with every diastole or relaxation, we become more plant-like and sort of almost go to sleep a little bit. So this is the rhythm, and again, the ratio of the breathing to the cardiac rhythm can be an important determinant of health. Generally, 1 breath per every 4 to 5 heartbeats is what's typical. And when that ratio gets higher or lower, we start to see different pathologies. We can think of so that's the general threefold division into the information system, rhythmic, metabolic system, but we can think of a threefold division in the respiratory system itself. At one end, we have the lungs, and at the other end, we actually have the gas exchange in the tissues, and that would be at the mitochondria, at the cell level, and the utilization of the oxygen in mitochondria. And the whole respiratory tract could be seen as an intermediate there. Same with the heart. We can see the heart more as the head of the cardiovascular system, the blood vessels as the mediating middle zone, and the capillaries as the metabolic zone in the tissues. So there's a further threefolding there. Again, this is more just to kind of show you, to help you think more about the relationships between these different systems. So the respiratory system is unique. It has a very special type of epithelium. And remember, epithelium is a special tissue that is usually one. It could be multiple layered, but it always rests on a basement membrane. And so all of our mucosal surfaces are made of epithelium. The respiratory epithelium is made up of ciliated, so it's columnar epithelium, so it looks like epithelium in columns. So if you look over here at this picture here, you see the epithelium looks columnar. It's attached to a basement membrane. Now what's interesting is that it looks like it's in multiple layers. So the way these cells kind of are arranged, it looks like actually there's different layers of columnar cells, but they actually, if you trace each one of them, only a single one touches the basement membrane. So sometimes we call that pseudo-stratified. But basically the columnar epithelium is ciliated. It has cilia on top. Now mixed in with these epithelial cells are special cells called goblet cells that secrete mucus. And so there's a mucus layer that covers the respiratory epithelium. And this is important, this ciliary motion. So the cilia is all the way down into your conducting zone, and those air passages is going to propel particulates, bacteria, whatnot, up towards the pharynx, and you can then spit it out or sometimes swallow it, but hopefully spit it out, and it'll get it out of the lung system. So that's part of what we call mucociliary clearance. It's the respiratory epithelium is, like I said, in most of the conducting zone. It's not present in the vocal cords, in the oral pharynx or the laryngeal pharynx. And that's because those areas, because of, for example, the oral pharynx is your throat if you go straight back from your mouth, and the laryngeal pharynx is the area right below that goes into your larynx and the vocal cords. That area gets a lot of food. That's where the food is passing, and so that tissue needs to be very firm and protected, and so that area actually has stratified squamous epithelium. That is flat cells, epithelial cells, and they're stacked in the layer. They're not ciliated, but they have a lot of protection, so this provides a mucosal barrier. The cells are all joined, both in the terms of squamous and the columnar epithelium, by tight junctions. And unfortunately, just like we can get in the gut a separation of those tight junctions and inflammatory processes, we can see that in the lungs as well, and that can create, I might call it leaky respiratory epithelium syndrome, and that can allow antigens and whatnot to leak in. Not a lot of research on that, but that's suspected that might be happening. I should say one more thing, that in this mucus layer of the lungs is a whole microbiome. So we're finding, just like in the intestines, we have a whole microbiome in the lungs, and there's a lot of research looking at how chronic lung disease is now related to changes of activity of that microbiome. The question is, which comes first, the change in the microbiome, or is it a change in the conditions in the respiratory epithelium, which depend a lot on what's going on in all the rest of your organs, including your liver, your kidneys, all your glands, your nervous system. All of that helps to determine the immune defenses and whatnot in the respiratory epithelium. So that's a bit of a chicken and the egg kind of thing, but we have people in both camps, some saying it's all about the microbiome, others saying, like myself, it's more about the conditions in the respiratory epithelium, and then the microbiome changes often in conjunction with that. But we are knowing there's a very important relationship between the microbiome and the respiratory epithelium. There are a number of glands that go kind of hard. Oh, I actually see it down in this picture here. If you look at the respiratory epithelium, here is the basement membrane, and here are the columnar cells with the little cilia on top. Cilia is like little hairs. They're actually made of protein, and they wave. They actually are able to wave. They have a motor activity, and again, that's what's going to create that washing movement on the mucosal surface. But deep down, going down into the submucosa, so the area underneath the mucosa, this is the mucosa, is the submucosa, we have glands. And these are called submucosal glands, and they secrete additional mucus and fluid, which gets propelled up to the surface here. And this is going to help with that mucociliary clearance. So if we look at the different cells in the epithelium, the main types are the ones I just talked about, the ciliated columnar cells. That's the most common, up to 80%. Each cell has about 200 cilia, and they beat at a rate of about 10 to 20 times per second, so very quick. motions. And they move the mucus up towards the pharynx, and again, that is called the mucociliary clearance. Interestingly, cigarette smoking often damages the cilia. So that's one reason why we see with cigarette smoking, we start to have less mucociliary clearance. You also tend to have more potential for infection because you're not able to clear all those things out. And even further damage from tobacco smoking will create an inflammatory process that can lead to chronic bronchitis and emphysema. And so we'll look at those conditions. So that is the ciliated columnar cells. There's also goblet cells, which are found here, and they secrete mucus. And they get fewer the lower down the airways you go. So by the time you get to the bronchioles, there aren't many goblet cells. But they're really creating the mucus in the upper airways to wash everything out. Now you have goblet cells in all of the tissues that arise from the endothelium. The endoderm, I'm sorry. The endoderm, remember, is in embryology one of your three primary germ layers that develops by the third week of development. The respiratory system, the epithelial lining, and the epithelial lining of the intestines, the whole GI system, comes from the endoderm. So the GI and the respiratory system have the same origin embryologically, and that's why we see a lot of overlap. We see a lot of goblet cells in the intestines as well as the respiratory epithelium. And we actually see that in terms of herbal therapies, there's a lot of crossover between herbs that treat the intestines, and they also treat the respiratory system. They're also club cells. They're called Clara. They used to be called Clara cells. Won't go into that at the moment. But they're found in bronchioles, deep down in the smaller airways, and they secrete immune substances onto the bronchial surface. So they have an immune role. There are basal cells, and those are stem cells, and they actually can differentiate into columnar and goblet cells. So the respiratory mucosa can repair and replace itself. Same thing with the GI mucosa, and the GI mucosa can replace itself every 2 to 3 days. In the case of the respiratory tract, it's a little bit slower, but it can still occur. And then there are another cell type in the respiratory epithelium called pulmonary neuroendocrine cells, PNECs. And these are also known as Kulczycki or K cells. They're found in clusters called neuroepithelial bodies, NEBs, and they're the least common cell type. Less than 0.5% of cells are these kind of cells. And they're interesting because they're innervated by the autonomic nervous system. So they're a direct way that the nervous system can communicate with the mucosal barrier there in the lungs. And these cells secrete a variety of hormone peptides, so serotonin, cholecystokinin, which is actually a gut hormone. It's actually the hormone secreted by the duodenum when you eat a fatty meal to tell your gallbladder to contract and to tell your liver to make more bile and to get more bile out of the bile ducts. Calcitonin, which actually is a thyroid hormone that regulates calcium metabolism. These are all secreted by these PNECs. We don't know exactly what the roles are of all these yet, but it's an area of active investigation. These cells can become cancerous, and so this is the source of several different types of lung cancers, in particular small cell carcinoma and bronchial carcinoid tumors. Carcinoid tumors are tumors of the serotonin cells. So we'll see with lung cancers there's several different types, but one type has to do with cancers of these specific types of cells. So what are the functions here of the respiratory epithelium overall? Well, it's to secrete what's called the airway surface liquid, ALS. And that consists of the mucus we talked about, but also immune peptides and different hormones like we just discussed. The ALS has two layers. There's an underlying layer called the watery or sol layer. So if we look at the mucus layer, like half of it is up here and the other half is over here. The lower layer is more thin and watery. And then there's an overlying gel mucus layer. The microbiome in both the lungs and the intestines is found in the mucus layer. And so the bacteria set up shop there, and most of them are very helpful. They give us nutrients and they provide immune defense. If they get into the watery layer, then we start having problems. And so we see the same thing happen in the gut when the bacteria start getting to that deeper layer. we start seeing more chronic inflammation. What happens is immune cells migrate up here, they set up shop, they start releasing inflammatory cytokines, and we start seeing the cells undergo all sorts of changes. So this is normally, though, to protect and moisten the airway, and it's a barrier to potential pathogens and foreign particles. There's the mucociliary clearance that we just talked about, and that is made up of the beating of the cilia that moves the mucus toward the pharynx, clearing the particles and the pathogens, and it relies on that water layer. Another more medical and technical name for this is the periciliary, so around the cilia sole layer, and the mucus layer. So it needs both layers. Now, unfortunately, cystic fibrosis, this is a genetic condition in which there's a mutation in the gene for the chloride transporters. And what happens is that chloride, which is needed to really thin the mucus and whatnot, isn't placed into that fluid. So what ends up happening is it becomes very viscous and thick. So in cystic fibrosis, the lungs as well as the intestines fill up with very thick mucus. And this prevents, in the lungs, proper breathing, proper mucociliary clearance. We see the same thing in chronic bronchitis and emphysema, and that's called obstructive lung disease, or COPD, chronic obstructive lung disease, or pulmonary disease, COPD. So both of those can compromise the barrier, and people will be more susceptible to infections. So one of the problems with cystic fibrosis and COPD is you get all this mucus. You got to almost turn upside down to let all the mucus drain out, and there's a much higher incidence of becoming infected with things because of all that mucus stasis. Again, I mentioned the respiratory microbiome, which is an important thing here, and the lungs have their own microbiome that has a protective role, and we think there is what we might call respiratory dysbiosis, just like we have in the gut, of an overgrowth of maybe pathogenic strains, not enough of the good strains, and that might contribute to chronic lung diseases. So that's the respiratory epithelium, very important, and we'll see that lining all the way down the conducting zone as we go here. So let's start with the upper respiratory tract. We'll start with the nose and the sinuses. So starting with the external nose, the visible portion of the face is the nose, and it's made mostly of cartilage. That's why it's flexible. That's shown in blue here. And there's a lot of different plates of cartilage, as you can see the lines there that come together. And it's attached to the nasal bone here, which is the hard bone. So when people say they break their nose, you can't break cartilage, but you can't tear the cartilage in the bone junction, or you can break the bone here and displace it. When a person breaks their nose, unless it's reset immediately, which is not common that happens, usually we have to let it heal, and then they have to go in for a procedure under anesthesia. They break it again and then reset it if it's blocking the airway and making breathing difficult. The nostrils are called the external nares. Use my marker here. The external nares are nostrils, and then air enters into the first part of the nose here called the nasal vestibule. And there are hairs there, and that filters out dust and particles and whatnot. So this is the vestibule right down here. And then we have the internal nose, and that's made up of the nasal cavity. The upper border of the nasal cavity is made up of the nasal bone. So again, here's the cartilage. Here is maybe I'll do it in pencil here. Here's the cartilage, here's the hard bone, here is the upper nasal bone. Notice that if you go back, there's actually a hole here, a pocket, and that is the sphenoid sinus. And then it goes down into the pharynx. So that's the upper border of the nasal cavity. And the lower border is actually made up of the hard palate, just here, and then the back part's the soft palate. And the uvula hangs here, and this is the oral cavity, the mouth down here. If you look at the nose from the front section on, it's actually divided into two compartments. There's a piece of cartilage that comes down the nasal cavity and cuts it into two, and that's called the nasal septum. And that divides the nasal cavity into a right and a left side. Now, if you look closely, there are these little projections into the nasal cavity. Here's one here, here's another here. These are called the turbinates. And what they do is they actually increase the surface area so that the incoming air can be moistened, can be filtered, and so forth. And that divides the nose actually into the nasal cavity on each side, left and right, into 3 cavities: the upper, the middle, and the lower meatices. Another name for those turbinates is the conchi. So the nasal conchi project into the nasal cavity. And so we have 3 separate passages here. We have a lower, a middle, and an upper meatus. Connected to the nasal passages are your paranasal sinuses, and there are little ducts called ostia, which connect. Your nasal lacrimal glands, those are tear glands that also go into the eye, also drain into the nasal cavity. That's why when you cry, often you get a runny nose as well. The secretions are going into your nasal cavity as well. Our paranasal sinuses, our main one here is below the eyes. This is the maxillary sinus. We have the frontal sinuses above the eyes, sort of in the brow area. And then between the eyes, we have the ethmoid sinuses. And then we have this one, the sphenoid sinus, which is at the back there. Now, sitting right inside there, there's a little indentation, and that is where your pituitary gland sits, right here. And that, of course, is attached by a stalk to your hypothalamus, and that's all part of that limbic system and so forth. This is important because one of the procedures for pituitary tumors is to actually go in with a probe and drill through the bone here, go through the sinus, drill through this bone, and then access the pituitary with a little endoscope. So those are the paranasal sinuses. Again, they drain via those little ostia into the nasal cavity. Unfortunately, if the ostia become obstructed, and that can become from chronic inflammation, from chronic mucus plugging and whatnot, that you basically then can get swelling and congestion in those sinuses. You can have an infection set up, and then we get sinusitis, and that can be either acute sinusitis or it can be more chronic. We have chronic sinusitis, and we'll talk about that later. Then we have the internal nares, and they connect these 3 meatises with the top of the throat, and that is called the nasopharynx, and that's going to be the top of the throat. The part of the throat right behind the oral cavity is the oral pharynx. Then we have the laryngeal pharynx underneath that, going into the larynx, the vocal cords, and the opening either to the esophagus or the trachea down here. We'll get to that. Notice that right here, the back of the internal nares are the adenoids, and that's one of your sets of tonsils. And those are saturated with immune cells, white blood cells, and whatnot. And they're your first immune defense of things coming in, bacteria and whatnot from the outside. And of course, in children, those can become enlarged from allergies. And they can actually become so enlarged they block the entire opening to the nasopharynx. And then a child starts to do mouth breathing. They can't breathe through the nose anymore. So that's where we do therapies to shrink the adenoids, hopefully address the allergies, but sometimes surgery is needed to actually remove those. One final thing I'll say is that up here at the top of the nasal cavity in the bone, there's a little plate, and you can't see it in this picture, but it has little holes in it, thousands of little holes. And there are little nerves that stick through those holes, and they all connect up here in the brain with the olfactory bulb, which goes back to the limbic system. So these little nerve hairs are sticking down there, and they put out little receptors into the top of the nasal cavity, and that's what's called the olfactory epithelium. So if you look at most of the epithelium in the nose, it's respiratory epithelium, like we just talked about with cilia and everything else. But this is olfactory epithelium. And so you see these, I don't have a picture of it here, but these little projections that come down, and they have sensory receptors for molecules, and that is part of olfaction smelling. This epithelium is replaced about every 6 to 8 weeks, so if you damage it, it can regrow in most cases. And humans have about 10 to 20 million olfactory neurons. We have about, I think it's 360 some different olfactory receptors. Interesting, a bloodhound has over 10,000, so much higher sensitivity to different smells than a human. And these neurons all merge to form cranial nerve number 1, which is your olfactory nerve. So that's located up here at the upper end of the nasal cavity. That's the olfactory epithelium. The whole purpose of the nasal cavity here is to warm, filter, and moisten the incoming air. It's to detect the olfactory stimuli. And the sinuses actually have an interesting role of, number one, creating more where if that air gets in the sinuses, it's going to be filtered more there. But also, when you speak, your sinuses help create a resonant cavity in your skull, and that helps with your articulation and your voice. And so if you've ever had a head cold or sinusitis, when they're all stuffed up, your speech often sounds very muddled and so forth. And so we actually need the hollow sinuses for proper speech and so forth. Now, we'll talk about sinusitis and what can be done, but the ostia, if they become closed, they can be opened surgically. And sometimes you can actually they can drill right through the bone here in the front of the face, and they create a hole there that periodically you can put a syringe through and actually aspirate and pull out the sinus material. That's a pretty intensive treatment, but I've seen that done in a few patients for their chronic sinusitis. So that is the nasal cavity and nasal passages. Now the pharynx, or the throat, same thing, extends from the internal nares to what's called the cricoid cartilage, and that's really where the trachea begins. Really this is part of both the digestive and the respiratory system. As part of the respiratory conducting zone. The walls are lined in skeletal muscle, the pharyngeal muscles, which assist in swallowing. So that's going to help with our swallowing reflex. There's 3 regions again. Again, the nasopharynx is what is up here at the back of the nasal cavity. It contains the adenoids. We also have in the nasopharynx the opening, I don't think it's shown in this picture here, the opening to the eustachian tube, and that's going to go to the middle ear. And that's where fluid from the middle ear will drain out through that hole into your pharynx. So we don't notice this, but this is a way of constant drainage. Now, in adults, if you look at the skull and the ears and eustachian tubes, adults, the eustachian tube is curved downward and drains into the narrow pharynx. In children, this is the ear. The eustachian tubes are more horizontal. So one reason children are more susceptible, we think, to middle ear infections is because they essentially have they can't drain that fluid out properly. There's an old naturopathic technique, which I don't use it much, but some of the people swear by it, is to actually reach around with the tongue, with your finger through the mouth up here, and then actually massage. So this is your uvula in your soft palate. You go beyond that, hopefully you won't gag, but then you massage the opening to the eustachian tube with a gloved finger with essential oils on it. And one idea is that can open up a chronically obstructed eustachian tube. So that's a possible therapy there. But the auditory meatus opens into the nasopharynx. The mucosa is all respiratory epithelium, and then we can actually find enlarged adenoids here. Another thing I failed to mention, we'll talk about that in the case of the respiratory pathology, is you can get swellings in those respiratory meatus called polyps. So that's different than the turbinates I talked about. The turbinates are normal. Polyps are an abnormal growth, and that can actually obstruct the meatus or more in the nasal cavity, preventing proper breathing. And that happens usually with either chronic infections, but more typically allergies, chronic allergies. The oral pharynx is the part at the back of the mouth, and that contains 2 tonsils, the palatine and the lingual tonsils. So what most people think of as tonsils are actually the palatine tonsils. So adenoids are actually technically tonsils, but they're again located behind the soft palate, so you can't see them if you open them out. You have to put your finger behind. In fact, the way that physicians visualize them is to put a mirror back there on a curve, like one of those dentist mirrors, and you actually can see with the mirror if it's enlarged and whatnot. But the palatine tonsils are here at either side. And then we have at the back of the tongue lingual tonsils, which are your third type of tonsil. And the oral pharynx, the mucosa here, is the non-keratinized. Keratin is a protein we find in the skin that gives the epithelium an even stronger barrier, but the epithelium here is non-keratinized, it's stratified squamous. So it's layers of squamous epithelium. And then we have the laryngopharynx, and that opens into the esophagus on the back side, and the larynx, and then eventually the trachea on the front side. So the air pipe is actually, the windpipe is in front of the esophagus. And the mucosa here is again stratified squamous epithelium. So we talked about the tonsils. These are again collection of lymphoid tissue. We have your adenoids. We have the lingual at the back of the tongue, and the palatine, which is what most people think of as the tonsils there. Clinical significance here would be pharyngitis, which is inflammation of the pharynx, and that could be acute or chronic, and we'll go through some of the causes, but there can be lots of causes. Viral, bacterial, we've heard of bacterial pharyngitis, which is often caused by streptococcal pyogenes, that's strep throat. It could be herpes virus, there can be candida. People can get acid reflux that causes chronic pharyngitis. The list is very long, so I'm not going to go through all that here. Pharyngeal cancer is another possibility, and that is usually squamous cell cancer or adenocarcinoma. Adenocarcinoma is a cancer of a glandular epithelium. So most mucosal surfaces will create adenocarcinomas. So those are the two typical pharyngeal cancers, and that's going to be more common in people that are smokers, have chronic alcoholism, chronic chewing tobacco, things like that can predispose one to pharyngeal cancer. And then tonsils, we can have enlargement, that's called hyperplasia, enlarged tonsils, and so we have enlarged adenoids, enlarged palatine tonsils. And so we can create, for example, the adenoid facies where children breathe through the mouth and not the nose. And then tonsillitis would be inflamed tonsils, usually the palatine. And then a tonsillith would be a stone in the tonsil, in the palatine or the lingual tonsils. These are very common. We'll talk about those, but they can create bad breath. They can set up pockets of potential infection and so forth. And then the procedure, tonsillectomy, is removal of the tonsils, and it depends on which one is being removed. So again, we'll talk about those in depth in the pathology section. So going past the laryngopharynx, we enter the voice box, the larynx. And this is at the anterior neck at the level of C3 to C6, cervical layers C3 to C6. And it connects the pharynx with the trachea. Except for the vocal cord region, this area is lined in respiratory epithelium. This is involved in breathing, of course, but also sound production and protecting the trachea against food aspiration. So the skeleton of the larynx is actually composed of 6 pieces of cartilage, and it's suspended from what's called the hyoid bone. So here's the hyoid bone up here, and then you have what's called the thyrohyoid membrane, and that's connective tissue. And then you have the big part here, which forms the Adam's apple, more predominant in males, and that's the thyroid cartilage. And then we have the cricoid cartilage, we have the epiglottis, and then a bunch of smaller cartilages I'll talk about here. But all of that forms the larynx. So the thyroid cartilage, again, connected to the hyoid via the thyrohyoid membrane. The cricoid cartilage, that's the ring of hyaline, hyaline connective tissue, or hyaline cartilage. That forms the interior wall of the larynx. So if you look at this picture down here, shows you a little bit of a clearer view of that. So here we have a cross section. Here's the cricoid cartilage. Here is the trachea. Here is the epiglottis at the top. Here is going to be your laryngopharynx right here. And then here, right down here in this very narrow opening, this is where your vocal cords and your vocal ligaments are found, right down in there. So all the air coming in and out has to actually pass through that narrow opening. So the thyroid cartilage forms part of the wall here, the hyoid bone, the cricoid cartilage, and then going into the trachea. Now the cricothyroid ligament connects, that's right here, that actually connects the cricoid with the thyroid cartilage, and this is where a cricothyrotomy can occur. So that's where a person who has any obstruction of breathing in the upper airways, and as an emergency procedure, they can actually make an incision here, right in and access. That's going to go right into this portion of the trachea, and you can then pass a tube so the person can keep breathing through that. So that's a cricothyrotomy. The epiglottis is a spoon-shaped piece of elastic cartilage, and it covers the glottis. It's kind of hard to see here, but basically when you swallow, it's going to cover the air passages, and that will allow the food to go down the esophagus, which is on the backside of the trachea here. And so that's going to prevent food from being aspirated into the respiratory system. Let's see, the three paired cartilages that regulate the vocal cords, so that's going to be inside here deeper, are the arytenoid cartilage, or the arytenoid cartilage, the corniculate cartilage, and the cuneiform cartilage. You don't need to memorize those, but just know those are all part of the laryngeal skeleton. We can divide it into a supraglottal region, a subglottal region, and then the glottis itself, the interior of the larynx. So that is the basic structure there. Now if we look at the vocal folds, these are elastic ligaments that are stretched horizontally across the larynx, and the tension can be adjusted, and that's regulated by a branch of the vagus nerve called the recurrent laryngeal nerve. And this is going to modulate the pitch and volume of speech, and that's called phonation. And then there are both intrinsic and extrinsic muscles which regulate both the respiration and phonation. So a lot of different muscles play into that. So forming sounds is a very difficult process actually, and there's a lot of different systems that are involved here. Now, where is this significant clinically? Well, there are a couple of disorders that can affect the larynx. So obviously laryngitis, that would be inflammation of the larynx, and that could be either acute or chronic. And we need to kind of search for causes of that. In terms of chronic laryngitis, there can be a lot of different features. Sometimes you can get polyps that grow on the vocal cords. You can get problems of that recurrent laryngeal nerve. That could be compression from a tumor in some cases, a esophageal tumor or even a lung tumor. And so that's why we usually do further imaging for chronic laryngitis to figure out what might be going on there. The otolaryngologist, the ENT doctor, can actually put a mirror in the back of the oral pharynx that can look down, and you can visualize, you can actually see the larynx, and you can see if there are any polyps or any scar or inflammation going on there. Presbylarynx is atrophy of the larynx. That's usually age-related. You can get ulcers and polyps and nodules that grow on the vocal folds. Laryngeal cancer, that's going to be more typical, again, in smoking and alcoholism, and several other disorders. But some of those are some of the main laryngeal disorders you should keep in the back of your mind. All right, so that is the larynx. Finally, we come to the trachea or windpipe, and this is what essentially connects the larynx with the lungs. It's a cartilaginous tube. It's about 1.5 to 2 centimeters in diameter in adults, and it's about 4 inches long, and it's wider in males than in females. The esophagus runs behind the trachea, and the thyroid gland lies on top of the trachea, right below the larynx. So if you look at the picture here, here is the laryngeal cartilage, here's your cricoid cartilage, here is your thyroid gland. Thyroid looks like a butterfly. It has 2 edges, and it looks like a butterfly here. There's a little bridge called the isthmus, and that stretches across, but the thyroid actually is on both sides. So if you palpate your Adam's apple and slide all the way down to the first little divot you feel on the trachea, that'll be right there by the cricoid cartilage, and go down a little further, you'll feel a little fleshy area. That's the isthmus, and then the thyroid's on either side of that. A lot of people think the thyroid's up here, and that's not the case. So I'll show you about the thyroid exam. I'll show you some examples of that. But basically, that's going to be the thyroid there. And I'll just say that behind the thyroid, if you peel it off, on the backside are usually 4 little glands. They're attached to the backside of the thyroid. They're called the parathyroid glands. And they secrete a hormone called parathyroid hormone, PTH, which is going to regulate your calcium levels in the blood. Very important hormone for calcium regulation. Without a parathyroid, you can't maintain your serum calcium, and that has all sorts of devastating consequences. Okay, so we'll talk about thyroid and parathyroid in another lecture, but the trachea itself begins at the cricoid cartilage. That's at the level of C6. And the epiglottis, of course, closes as preventing food from going down the trachea. And the trachea ends at this region down here where it splits into two tubes, and these are the primary bronchi. One goes into the right lung, again that's patient's right. One goes into the left lung, patient's left. And then this area down here is called the carina. And the carina is important. This is the level of T6. It's where there are nerve endings, and any mucus that falls down, going down, 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 hits the carina will trigger the cough reflex. And so that's a common thing with postnasal drip and whatnot. The mucus will trigger, and it'll trigger coughing at the carina. The mucosa on the trachea is all respiratory epithelium again. And there are about 16 to 20 C-shaped rings. So if you look at the trachea in cross-section, it's got these C-shaped cartilaginous rings. Then here's the trachea itself. It has a little muscle layer. It has a submucosa and a mucosa. And the mucosa is the respiratory epithelium. And the esophagus is back here. So this is important because usually the esophagus is kind of flat between eating, but when food goes down, it's got to stretch out. And because of the rings, it can actually stretch a little bit into the airway. So that's why the rings don't go all the way around the windpipe. Unfortunately, the rings can calcify with age, and so that can make it a little stiffer, a little more difficult sometimes to swallow because it's harder for the esophagus to kind of expand into that space. So that's the basic anatomy of the trachea. So that covers the anatomy for the upper respiratory tract. In the next video, we'll jump into the lungs and look at their internal structure.